I work, as Christo said, in Varese, so you are all welcome to say Professor Castelnuovo in the operating room here in Varese, and my topic is a little bit difficult, but I'll try to give you some important message. And the approach to the infratemporal fossa and upper parapharyngeal spaces. Previously, before starting this kind of surgery, it was mandatory to understand really well the anatomy in this difficult area. And Jacopo Dallan helped us a lot to understand on the landmark that guides us during this kind of surgery. We tried to standardize the approach toward this area. And what we suggest you to do in order to arrive to this target is to divide this kind of surgery in 5 main steps. So, first of all, if you have a huge lesion that involves also the nasal spaces, you need to reduce the mass in order to move laterally towards the pterygopalatine fossa and the infratemporal fossa. It's important to lateralize the fulcrum of your instruments. So you cannot work in the infratemporal fossa leaving intact the medial wall of the maxillary sinus. So first of all, gain space towards your target. This is a minimally invasive approach. You enter from a small space, but you have to perform a maximally invasive approach in order to remove the pathology. And third thing, you have to remove the posterior wall maxillary sinus or the palatine bone in order to get these areas. And then you have to orientate inside the infratemporal fossa and upper parapharyngeal spaces. Don't forget always to cover the vascular structures when you expose them. And again, this is an important concept. Here, the medial wall of the maxillary sinus. Here, the piriform aperture. If you want to work straight here by manually, you need to remove the incisor, the piriform aperture, in order to work with 2 instruments and the optic system towards your target. This is what we do usually when we work here. We remove the anterior wall of the maxillary sinus till V2. You can go also over laterally if you need it, but it's mandatory to remove at least the anterior wall till the vertical plane passes for the second branch of the trigeminal nerve. In such a way, you see, in the next slide, you expose the posterior wall of the maxillary sinus, and you can work with the optic up and the 2 instruments below. In such a way, you can control the billing, you can dissect the mass, and it's the best way to avoid complication. Of course, it depends from your technology, this kind of approach. It depends from your exposure, but it depends from the pathology. It's very different to treat a benign lesion like a JNA, juvenile angiofibroma, or to treat, for example, recurrence of an undifferentiated carcinoma after radiochemotherapy for a salvage surgery. Why this? Because this is a huge juvenile angiofibroma, but we approach endoscopically. Of course, this is an extreme surgery, but the concept is that a benign tumor has a capsule. And if you follow the capsule, you can remove this kind of tumor. Instead, if you have a small tumor and you have to remove it, you have to take the landmarks. In this case, you see, this was a young guy from Egypt, referred to our hospital. You see, this is a huge mass involving all the sinus, but as you can see, you follow the capsule. You see the capsule of the tumor, you see? You have to pull and dissect following the capsule of the tumor. Infratemporal fossa, yes, it's a dangerous place, but if you follow the capsule, your risk is reduced. Another thing, instead, this is the postoperative MR, is to treat malignant tumors, recurrences, or primary tumors that don't respond to radiotherapy or chemotherapy. In this case, you have to take your landmark on the skull base and inside the infratemporal fossa. You see here you have a lot of structures, a lot of muscles, so you have to recognize the tensor veri palatini, the medial pterygoidal muscle, the lateral one, the temporalis muscle, the maxillary artery, and the carotid. So, step by step, you have to identify all these structures, the tube, that is its important landmark, I'll show you later, and in such a way, following these landmarks, you will arrive to identify the carotid in this parapharyngeal tract, preserve it, and remove this tissue all around the tumor with safe margins. So, this seems easy, but sometimes when you are near the carotid, you feel like Wendy. You really, I assure you, is something scaring, because you know landmarks, but with the radiotherapy, then at the moment you have to close your resection and the carotid is behind you. So you need to know the landmarks, but you need also an intervenist, a neuroradiologist that can close the carotid if something happened during this kind of surgery. And one of the most important landmarks, I think the major one, is the Eustachian tube. The Eustachian tube, as you can see here, protects you from the carotid in the upper part. So this is the paraclival carotid artery, then there is the petrous one, and then the parapharyngeal. In the upper part, the tube protects you from the carotid. When you see the tube, you are relaxed. When you have then to resect the tube, go behind, you start biting your heart. So the Eustachian tube protects the carotid in the upper part of the parapharyngeal spaces. And we follow the structures in order to remove the tumors. This is an anatomical example. You see here V2. This is the third branch of the trigeminal nerve. Here anterior and lateral to the Eustachian tube. Here V3, the tube, medial genu of the carotid, and the median nerve. Here, the middle meningeal artery, okay? If you are anterior to these structures, nothing can happen. But if you go inferior, at this level, you can damage the carotid. So, first landmark, the Eustachian tube. And then, of course, you need safe landmarks, not soft tissue. And so, the upper landmarks at the level of the skull base have these four golden four landmarks that are the foramen ovalis, the foramen spinosum, where the middle meningeal artery passes, the spina sphenoidalis, and then the musculotubular canal at the level of the skull. Following this landmark, you see you arrive at the level of the carotid canal, looking for the carotid. And now I show some examples. You see here, we start always with the resection of the medial turbinate, and you see a tumor at the level of the lateral wall of the rhinopharynx. We always take our landmarks. Here we open the sphenoid, the intersphenoidal septum. We identify the intersphenoidal septum and the clavicle carotid artery. Then let's drill the piriform aperture, perform a medial maxillectomy, you see, and then after these two steps, you can drill the posterior wall of the maxillary sinus. Here we remove the posterior wall, the descending palatine artery. You see here we are in the pterygopalatine fossa, the pterygoid behind. Here we cut the median nerve and we push the content of the pterygopalatine fossa laterally. Lateral pterygoid plate, medial one, and here the medial canal. Don't try to go inside the fossa if not necessary, because there is a tremendous venous bleeding. So here you start drilling the pterygoid and to control the bleeding from the pterygoidal plexus. And again, here the tumor. Now we want to remove all this area around the tumor with safe margin. We use this kind of instrument, diodide laser, that coagulates at the same time that they cut, and we have to identify the tensor levator palatini muscles and the levator valve. If you go straight to this direction, we will find the carotid. You see, we use the Doppler in order to avoid to damage the carotid, because in the upper part we have the tube, but here inferiorly we don't have the tube, so we have to identify with the Doppler the artery. And then we go laterally, we can cut the levator, the tensor veripalatine muscle, and we have to stay at least an half of centimeter, 1 centimeter from the tumor. And with the laser, you cut the muscles behind the longus capitis, the longus colli, and here all the tumor that we orient and we send for histopathologic examination. And again, of course, this was not the previous one was not a tumor so near to the carotid, but in such a case, you need also to identify the upper landmark, V3, and the middle meningeal artery and the spine of the sphenoid in order to identify the carotid, because the tumor is very near to it. So what we use is a navigation system. Here we are at the level of the skull base, and this is V3, this is the tube, you see, medial genius of the internal carotid artery, and we identify V3, medial meningeal artery, and here medially we know that there will be the carotid artery, the lateral genius, this one. You see, this is the carotid, paraclival, petrous, and parapharyngeal. We can identify it, skeletonize, and remove the tumor all around. Of course, you have to cover the vessels. I had one mistake. Once I removed a huge chondroma in the infratemporal fossa, exposing the internal carotid artery, okay, in this parapharyngeal tract. I just covered with some fascia, and I had a blowout of the carotid after 20 days. So let's always cover the vessels with the vascularized flaps. And this is mandatory, I assure you. And so these are our results. Of course, they are malignant tumors. We have one major complication that is a rupture of the internal carotid artery. You see here, we are on the right side, parapharyngeal spaces, drill, boom, carotid. Okay, it was one of our first cases, and so you have to improve your anatomy, to work in a lab, and to try to identify one landmark after another in order to avoid this complication. So she was referred to the for embolization. He closed the carotid, and now she's alive. It's okay. Anyway, this is a very dangerous surgery that you have to perform in very selected centers. And the second topic, I will try to 40 minutes. Perfect. Unbelievable. I have other 15 minutes to show you my other topic that are complications. So,
are there any questions from the audience? Anyone? Some questions someone would like to discuss?
So my second topic is about complication. This is my favorite sentence. Wolfgang always says the only ones who don't have a complication are those who don't operate. This is real. Everybody who operates has a complication. Of course, we have to try to reduce the possibility to have it, and what we have to evaluate is the habitus of the patient, the comorbidity, if it takes funds, etc. And of course, we have to evaluate ourselves and to know how is our preparation and our experience. And we need, of course, instrumentation, and of course, we need a system that can permit us to follow the patient. But let's go straight to the topic. And of course, complication are higher and important, as much higher and important is your surgery. Of course, in level, and you need to know how to avoid it, because these are disastrous complications. You see, in this case, the surgeon was completely without landmarks. He enters with his aspiration inside the third ventricle, okay? And in this case, the surgeon entered inside the lobe, but he didn't stop. He took away the globe like a polyp. So you have to know where you have to stop in order to avoid this kind of complication. Of course, if you perform standard routine endoscopic sinus surgery, the complication could be less than if you start working on the middle and posterior skull base. Anyway, these are things that can happen. For example, here we were performing an approach to the frontal sinus. We were drilling, you see, like Christos this morning, the lateral wall of the orbit in its supraorbital recess, and this is what happened. The fat came out, but in this case, you have to recognize it, coagulate the fat, and everything is okay. In this case, you see, we coagulate the fat. We say to the patient not to sneeze after the surgery, and usually there are not problems. If you go on and you go on the superior oblique muscle, that starts the problem with the diplopia postoperatively, okay? And another complication here, the lesion of the anterior ethmoidal artery. It can happen, but if you cut the artery in such a way, you don't have to be scared. You only need the bipolar forceps. With this kind of forceps, you see, you can arrive to the bleeding point, coagulate the artery, and stop the bleeding. But if you have a bayonet, is it right? A bayonet, it's very difficult, because sometimes the movements inside the nose are very difficult. So you need this kind of bipolar forceps that opens on the tip. This is the first thing you have to buy when you start to do this kind of surgery. And you see here, in such a way, you can coagulate the artery. You don't, and you have always to use cutting instrument on the skull base, because if you cut the artery, you can coagulate it. But if with the bascally, you strip the artery, it goes inside the orbit and then starts the problems. So cutting instruments and bipolar forceps that opens at the tip. And unfortunately, there was, you see here, this can happen. It's the same case always, you know, 3 complications at the same time. So it was not me operating. And here, you see, removing a bony shell on the posterior wall of the frontal sinus and rhinolacorea. It's something that it can happen. You have to be prepared. You can take a free flap, or you can rotate a vascularized flap at the level of the anterior ethmoidal artery, but you know that this can happen. And this was referred to our center for this reason. You see here, the surgeon, through the ethmoid, enter inside the orbit and went inside the intraconal space. With the debrider, he debrides the medial rector muscles and touched the optic nerve. The patient was blind when he came in Varese. So what we did is was trying to decompress the orbit and try to decompress the nerve. Let's see what happened. Here is the sphenoid. Here, the orbit. This is the inferior rectal muscles, the medial rectal muscles. We decompressed the optic nerve. We removed the bony shell around the annulus of Zinn, and we cut all the periorbit. But what happened, you can see it in a few seconds. See here, cutting the shell covering the nerve. The patient, the surgeon entered here. You see, between the inferior rectal muscle and the medial one. See here the hematoma? The patient did not recover. So pay attention using the debrider. It's a great instrument, but we have always to control the tip. You have to always to know where you are. If you are disoriented, stop it. Stop the surgery if it bleeds too much. It's not important, because if you go on, you can do such kind of things. And again, if you want to start advanced surgery, complications start becoming more and more important. So I show some cases. You see here, anterior skull base surgery. Here, if you strip it, it can happen something like that. And you have to be ready to coagulate the artery with this kind of forceps, as I told you before. And or you are able to decompress the orbit endoscopically if you remove the ethmoid, or if the patient, the eye of the patient starts growing and growing, you have to have in your background this simple procedure, the lateral cantotomy. The nerve, when it starts bleeding inside the orbit, it's not a problem of the bleeding. The bleeding will stop because it's a closed cavity. But the problem is that the nerve is stretched. And so you have to decompress the orbit. And this is, I think it's very easy. You only have to have two scissors, point the scissor on the bone and cut on the lateral canthus. And you decompress the eye. And again, what can happen here, if you are drilling, for example, on the clavus, you have to be able to manage with venous bleeding. You see here, the dura was open. Here, the sella, the paraclavial carotid artery. What to do? You cannot press too much behind. There is the brainstem. And so you have always to have, of course, your bipolar forceps, but also to have this kind of material that can stop the venous bleeding. You see here, you can try to use this kind of forceps, but with the venous bleeding, sometimes it's not so easy to stop it. So this kind of surgical, you put the packing, you have to use warm water to take your time, and usually the venous bleeding stops. Here we have to move on because we have not much time. I want to show you some other complication, but it will take 5 minutes. So the carotid, so the damaging of the internal carotid artery. What to do? And I will finish, because sometimes it can happen. This is a case that was performed by my colleague. You see this lesion at the level of the clival, and they were performing a biopsy. They needed a biopsy to know what was a chondroma, a chondrosarcoma, what else, a dysplasia. They needed to know what it is. You see here, this was a really bad mistake. Directly at the level of the lesion. Never do that. Let's identify the landmarks. This is what can happen with the drill directly on the clivus. But here, there was the paraclival carotid artery. You see here, bleeding. And what to do in this case? You need hemostatic material, see, put on the carotid and try to stop it. But the problem is the pseudoaneurysm that can be followed to this kind. You can stop the bleeding, but you have to follow the patient during next month because it can start creating an aneurysm at the level of the carotid. So this is an example. And another example here. This was with Professor Locatelli. A huge tumor, very fibrous inside the cavernous sinus, trying to dissect the tumor for the carotid. You see? One and two. Start bleeding the carotid. And again, what to do? You have to pack. You have to use the muscles. You have to use the Warman clip. It depends what you have. In this case, we use Frosil, Surgicel, and then fibrin glue in order to pack and send for the closure of the artery. And then going on again on the lesion. You see here? We stop the surgery. And we closure the artery, and then again to approach the tumor. Just another thing, I think the last one, please. When you have a monolateral new formation at the level of the sphenoid, always perform an MR, because this is not a hemicotic sinusitis, but as you can see, it was an aneurysm of the paracavernous carotid artery. So every time with the monolateral neoformation of the sphenoid sinus, perform a TC and MR, because a neoformation inside the sphenoid can be a meningocele or, such in this case, a pseudoaneurysm. And of course here, all the way, I did this course of Wormald on the ship, you see this kind of instrumentation, but the problem is, as I showed you before, when you are damaging of the internal carotid artery, usually you don't have all the artery exposed in such a way. Perhaps you have the bone all around, so it's difficult with the kind of forceps to take the artery and to suture it. I think the best thing that Wormald said to us, and have to take, all of you have to take in mind if you are planning to do this kind of surgery, is not the use of this instrument, the clipping of the artery, but is this one. And then I will stop, because if it happens, this can be really an alternative of using Tabotam or Surgicel. So you can use the muscle pedal. You can take a piece of muscle from, for example, from the leg of the patient, from the sternocleidomastoid patient, it starts bleeding, and I tried it. It works, really. I don't know why. You take the muscles, you crush it, and you put on the vessels. And here there are some factors that can reduce and stop the bleed. So, or you pack and send it for neurovascular procedure, or you can use, for example, a piece of muscles. So I stop because my time it's over, and thank you again, and thank you, Kristen, for your kind invitation. It was a pleasure to be here.